Okay. We may start because we have only half an hour for this interesting topic. I am Luca Anzaloni from Italy. I am a general and emergency surgeon. And today I am very glad to introduce a speech by Yilmaz Sergin, that is a professor of surgery, of general surgery here in Turkey, and he will do a speech related to the use of urgent ERCP for critically ill patients, and is a survey that was done here in Turkey. So thank you very much, Professor Yilmaz, and you are ready to do your speech. Thank you again.
It's a great honor and pleasure for me to make this speech from here, and so I would like to thank the organizing committee for invitation for this speech. But of course, the most of the celebrations to, of course, to Dr. Mehmet Yilmaz for this amazing organization, and I would like you to welcome to Turkey to this amazing Congress and also amazing country for being us. And my topic was urgent ERCP procedures, and I am going to present my speech with mainly the articles of the authors from Turkey. And the endoscopic retrograde cholangiopancreatography, and briefly, ERCP is an invasive endoscopic procedure, and that is performed by a specialized side-viewing duodenoscopy and also the fluoroscopy system. So it's a high-skilled invasive endoscopic procedure that requires high experience and also the endoscopic education. Okay, and here is the brief technique of ERCP and the tip of the duodenoscope. You see here there is a control panel at the head of the duodenoscope, and there are switches, locks, and an elevator system. Insertion of the duodenoscope you see here, and the face-to-face position, and through the papilla, and the papilla is edematous and swollen. And please be note that there is an impacted stone at the orifice of the papilla, and with a nice pre-cut incision, a simple extraction of the stone could be achieved. You see at the left upper side, this is occlusion cholangiography, and they should be obtained at the end of every ERCP procedures. You see, and this is called occlusion cholangiography, confirming that the bile diagram without any residual stone. And when we look at through the current status of the ERCP procedures in Turkey, we see that the ERCP procedures are performed mainly by the general surgeons and the gastroenterologists. So it is estimated that approximately 9,000 to 10,000 of ERCP procedures are carried out by nearly 200 general surgeons every year. And for general surgeons, there are two sources of ERCP training, and basically through the general surgery residency, and after the residency as a postgraduate course of Turkish Surgical Society for 6 months. And you see the ERCP training program in our clinic, and at the left side, you see our ERCP training book that we have published before for the ERCP trainers. And all the trainees are supposed to read this book before the training. And at the right side, you see the certain maneuvers with body movement and the tip articulations also, etc., to obtain the face-to-face position of the duodenoscope through the papilla. And although it is a simple procedure, but what we should not forget at every moment of the procedure is that for 100 persons who undergo ERCP, seven of them unfortunately develop severe complication, and one of them unfortunately dies. So when we look through the complications of ERCP from an article of my friend Dr. Uğurlu from Urfa that is located at the southeast part of Turkey, it's shown here that at the left bar, green one shows the frequencies. At the right, the mortality is shown here. The most frequent complication of ERCP is, of course, pancreatitis, and the least one is the perforation. So although perforation is seen very, very rarely, the mortality rates, unfortunately, the mortality rates of it ranges between the 10 to 30%. And this is a case of perforation. You see the papilla here, located at the edge of a mucosal fold, and very mobile and invisible papillary orifices, and several precut attempts you see here for the cannulation. And unfortunately, please note that at the right upper side, there has been a perforation occurred after this procedure. And this is then another severe complication, bleeding. You see there is a giant diverticula here, and the papilla is located at just the end of the diverticula. With the endoscopic sphincterotomy, a sudden bleeding has just occurred here with the drainage of the infectious material from the bile duct you see. Of course, in these instances, or in such cases, you should stay your calmness and don't panic, because there are several measures to stop the bleeding at this time. So these are the adrenaline injections, balloon occlusions, etc. But if they fails to stop the bleeding, of course, you can use, as in this case, a full covered, self-expandable metallic stent to stop the bleeding. And this is our recent article published in World Journal of Gastrointestinal Surgery this year. And this study includes the results of ERCP procedures of nearly 70,000 ERCP patients. And it is a multicentric study. It's an observational study with the contribution of 15 general surgery clinics in Turkey. And I think the number of the patient is large enough to make some conclusions and statements about the ERCP procedures of the general surgeons. So when we look at in detail the article, the results are shown in this table. And please note that at the right side, you see the criteria of British Society of Gastroenterology, the criteria that has been declared by the British Society of Gastroenterology. These are the targets that every ERCP endoscopist or ERCP units should achieve these targets. And at the left side, you see the results of the surgical clinics. And we see here that the cannulation rate 90.8%, complication rate 5.6%, complete bile duct clearance rate 84%, and the successful standing for the strictures is 82%, in which all of these results are comparable and acceptable when compared to criteria of British Society of Gastroenterology. However, I think one of the most important results of this study is that 43.6% of all ERCP procedures were performed for urgent issues. Nearly half of them, please note that. And it indicates that, every trauma and the emergency care clinics should have an available ERCP unit working in non-stop and truly efficient, because nearly half of the procedures were performed for urgent issues. And when we come back to the results of the article, so we see that the urgent issues requiring the ERCP, emergency ERCP, are cholangitis, bile duct injuries, certain parasitic infestations, and the pancreatic diseases require urgent ERCP. And when we look at the cholangitis, as you all know that the cholangitis, especially the suppurative cholangitis, is a severe infection of the bile ducts, and that rapidly progresses into a life-threatening clinical consequences. So most of the time, it accompanies a bile duct stone or cholecystitis or sometimes pancreatitis. So in such instances, urgent ERCP is a life-saving procedure and is required as a bridging process preceding the following cholecystectomy or the other surgical procedures. So this is an article from Ankara Bilkent City Hospital and recently published in the Journal of Hepatobiliary Pancreatic Sciences. And my colleagues have emphasized in this article that the importance of the ERCP before definitive surgery for the patient with the acute gallstone pancreatitis. And this is one of my patients. You can easily see here spontaneous purulin drainage of the purulin material from the bile duct. You see at the left upper side, cholangiographic view conforming the bile duct. And please note that there is a giant diverticula here. This is an interdiverticular papilla. With the endoscopic sphincterotomy advancing through the cranial position, you see a nice decompression of the bile duct can be achieved here. And the bile duct injuries, of course, are severe problems and the next issues requiring the urgent ERCPs. And we know that the cholecystectomies are the most frequently seen etiological factor for bile duct injuries. Just in Turkey, around 600 to 2,000 bile duct injuries occur every year after cholecystectomy. Obviously, the Strasberg classification, of course, is mandatory to identify the injury. And this is a nice article from Van Yüzüncel University, and that has just been published in the Journal of the Turkish Association of the Trauma and Emergency Surgery. And here my colleague stated that most of the injuries following cholecystectomy are in Strasberg type A injuries and can be treated with ERCP-based treatments. And this is one of my patients, and you see this patient had been referred to our clinic with the bile fistula after cholecystectomy. You see occlusion cholangiography confirming the bile leakage from cystic duct stumpf. And this is papilla, and the cannulation is very difficult. Then pre-cutting maneuver should be tried. And you see, after the cannulation, you see with a limited sphincterotomy in order to prevent the migration of the stent. And we have placed an introducer first, and after that, for such kind of cases, most of the time 10 French, 12 centimeters, Amsterdam type biliary stents are enough. As you see here, a plastic stent is advanced through the bile duct over the introducer, and it should be confirmed under the fluoroscopic view. And and you see, we have introduced this stent here and confirmation of the stent through the bile duct and bridging. Please note that the stent should bridge the cystic duct stumpf to prevent the biliary leakage. And the parasitic infestations, of course, are prevalent in some part of Turkey, and the parasitic infestations may present with different clinical pictures, like obstructive jaundice and cholangitis, allergic reactions, and as well as some cancer mimicking scenarios. So just for hydatid cyst, there are over 4,000 cases per year in Turkey, mainly involving the liver. And this is our present report that has been published in Turkish Journal of Surgery. And here we have reported the parasitic infestations encountered during the ERCP procedure. And as expected, that we have observed 19 cases of germinative membrane particles, and the 2 cases of fasciola hepatica, and the 1 case of ascariosis in the biliary tract during the ERCP, nearly out of 3,000 cases. And this is one of my patients. You see the ERCP cholangiogram and several filling defects in the bile duct you see caused by the germinative membrane particles. And during ERCP with enough endoscopic sphincterotomy, you can use balloon catheters or the endoscopic basket catheters to remove the glycemic germinative membrane particles from the bile duct you see. In some cases, you may also encounter with the daughter cysts, of course, to extract with the germinative membrane particles. And this is another case. You see a germinative membrane extraction after a bloody sphincterotomy, unfortunately. But this time, please note that the germinative membrane particles are bile-stained and infectious in character. So this clearly demonstrated that there is a big gap between the cyst-hydatid and the biliary system. There is a connection, cystobiliary connection, we call this. And you see with the balloon catheter, nice extraction of the germinative membrane particles can be observed here. And this is a nice article from Istanbul by the Alpen, Ali Kocataş, and Kemal Dolay, my friends from Istanbul. And they concluded that in selected cases of hepatic cyst-hydatid, ERCP considered as a definitive treatment option without any further surgical intervention for cyst extraction. So if there is enough connection between the cyst and the biliary system, then ERCP can be used as a definitive treatment. So next parasite is Fasciola hepatica, and Fasciola hepatica is an endemic zoonotic disease in Turkey and some part of neighboring countries. And it is a zoonotic disease, and the natural host is sheep, of course, and the human being is accidental host. So actually it is an intraluminal parasite located in duodenum. From here climbs upward through the bile system by penetration and settles in the biliary tree. And then after extraction, triclebendazole, an antihelminthic drug, will be enough for eradication without any surgical intervention. And this is a case report of a patient with Fasciola hepatica. This report from the Çukurova University that is located at the Mediterranean part of Turkey. And here the authors have demonstrated a patient with Fasciola hepatica admitted for cholangiocarcinoma. So mimicking scenarios with cancer is important for Fasciola hepatica. And this is one of my patients that had also been referred to our clinic with the suspicion of a cholangiocarcinoma. So we have decided that ERCP for differential diagnosis, mildly dilated bile ducts on CT scan, and you see an obscure papilla here and the difficult cannulation. But after the cannulation on cholangiographic view, and you see here this is sphincterotom, and you see, please, occlusion cholangiography, there is a filling defect here, considering the cholangiocarcinoma actually. But during endoscopic sphincterotomy and after extraction, we have observed moving viable flux, fasciola flux, extracted from the bile duct. And after a triclebendazole antihelminthic drug, the patient did not require any further surgical intervention. And of course, the last issue concerning the urgent ERCP is, of course, pancreatic diseases. And ERCP has a definitely strong place in emergency traumas, walled-off stages of necrotizing pancreatitis and the acute biliary pancreatitis secondary to impacted bile stone at the common channel. And the diagnosis of pancreatic duct injury, pancreatic fistula following blunt abdominal trauma is very difficult. So this causes a delay in treatment and also increases mortality and morbidity. So for such cases, ERCP is valuable in diagnosing the Wirsung disruption by Wirsungography, and also ensures the definitive treatment by placing a stent through the Wirsung channel. And this is an interesting case report published in Military Medicine by my colleagues from Gülhane Military Academy in Ankara, the capital of the Turkey. And here you see they demonstrate a 21-year-old male patient with the pancreatic fistula. They diagnosed the patient with ERCP by observing Wirsungography, the pancreatic leakage from the Wirsung channel, and treated the patient with just placing a stent through the pancreatic channel. And this is a pancreatic fistula following blunt abdominal trauma. Thanks to Kemal Dolay for this nice video. And you see a pancreatic standing is performed here. And the placing a stent is much more difficult, of course, the biliary standing, because of the articulated structure of the Wirsung channel. And following the placement of stent, the introducer is withdrawn and the stent is placed here, and this patient did not require any further surgical treatment. And then if there is a pseudocyst accompanying the pancreas injury, so the first, it should be drained to stomach with a full cover stent. You see, this is one of my patient, and with endoscopic ultrasound usage or just by gastroscopy. And then an ERCP should be performed here with limited sphincterotomy. And after that, 4 pancreatic traumas, 7 French, yes, you see the leakage area. This is a 7th French stent will be placed here. You see, stent was nicely placed through under the fluoroscopy control to Wilson channel. And of course, necrotizing pancreatitis are severe catastrophic problems with the mortality rates of nearly 10 to 30%. And the surgical interventions are usually, mostly useless and hopeless. So the endoscopic treatments or the supportive measures are strongly advised. And this is one of my patients, you see. And here there is a severe necrotizing pancreatitis. And it is at the wall of necrosis stage, and there are several air bubbles in it. And also there are severe inflammation around the peripancreatic tissues and also the peripancreatic organs. So we have decided an endoscopic approach for this patient. And first of all, we plan to place a stent between the stomach and the pancreas with a colonic stent, self-expandable. You see, this is a guide wire. And we have placed a self-expandable, full-covered colonic stent between the stomach and the necrotic pancreatic areas, you see. So drainage of the liquid portion of the necrosis through the stomach. Then inside of the stent you see here, and this is ERCP cannula, with the vigorous irrigation with the oxygenated water. We have clearly irrigated the wall of necrosis area, and you see clear inflammation and the severe purulent material drainage from the necrotic pancreatic tissue through the stomach. And after that, this is the second step, endoscopic necrosectomy through the stent. You see, with the endoscopic forceps or sometimes with the basket, you can perform several cycles of endoscopic necrosectomies till the fresh bleeding viable tissues were obtained beneath the necrotic tissues. And of course, biliary pancreatitis secondary to impacted stones, although it is not as severe as necrotizing pancreatitis, of course, but still has a mortality rates of 1 to 3%, and it is caused by a obstructed stone obstructing the common channel that is formed by the union of the bile duct and the Wilson channel. And this is an illustration how a gallstone occurs bile pancreatitis. You see, a stone is dropped from gallbladder, obstructs the common channel, and increases the intrabiliary and the intrapancreatic pressure also, and then the acute biliary pancreatitis develops. And this is one of my patients. You see, with acute biliary pancreatitis due to impacted stone, and with a small pericutting incision, you see a nice removal of a stone at the just orifice of the papillary orifice. You see the stone at the tip of the needle. And another case, you see how bile and pancreatic juice flushes after the extraction of the stone from the bile duct, and relieving the patient also the clinical condition. So my last session is if you are performing ERCP extensively, so you can always face with an unexpected solutions, and you could have to find an immediate solution during the ERCP. So define the problem, choose one of the alternative, and do it immediately, because we know that the structure of every papilla is different from another papilla. There is no standardization. And this patient had been referred to our clinic with the obstructive jaundice due to a bile stone. But during the ERCP, we couldn't manage duodenal curvatures, we couldn't advance duodenoscope, we couldn't find papilla. Since we realized that this patient had a situs inversus totalis, so we decided to switch the patient from the left lateral decupit position to the right lateral decupit position, because the patient had situs inversus totalis. And you see here, this patient is in right lateral decupit position, not left. This is switched the position. So operator is on right. The TEMS and the video endoscope system is on the left. So in this position, it is very, very difficult to perform ERCP. But at the end of the procedure, we were able to cannulate the bile duct, and please see that there is a huge stone here extracted from the bile duct at the end of the procedure. So basket impaction is important. So what does it mean? Basket stuck or impact. So in such case, you can catch the stone, but you can neither remove the stone from the papilla nor separate the stone from basket. This is a stone impaction, basket impaction, and this is a real emergency state. In these instances, of course, if you have a lithotripsy system that can you integrate it with your duodenoscope, you can use it without any requirement of the surgery. But if you do not, of course, laparotomy is still a surgery, laparoscopy is still a surgery. So you can perform surgical approach, choledochotomy with laparoscopy or laparotomy, and open the bile duct and extract here the bile and basket complex, stone and basket complex, and place a T-tube briefly. But if you have a lithotripsy system, so you can use it. Please see that here, the stone is catched by basket, but it's impossible to remove the basket from the papilla, but also it is impossible to separate the stone from the basket. So here you see the plastic sheet is cut, and this is the metal wire of basket, and the duodenoscope is removed, and you see metal wire coming through from the basket, and this is introduced into a steel sheet. And after that, this steel sheet is attached to a pulley system. You see, after fixation, then this metal sheet is going to be advanced through the stone and the basket complex under the vision of fluoroscopy, and we'll see it. And after fixation, and we are advancing through the, you see, sheet is here, and approaching the stone and the basket complex, and the then pulley system is starting to squeeze the basket now till the fragmentation. And please, you see here, please note that the fragmentation of the basket has been ensured nicely, and another ERCP after that, of course, will be performed for the extraction of the stone fragments. And the diverticulars is are important problems for ERCP endoscopies because they decreases the cannulation rate, successful cannulation rate, and also the increases the mortality and morbidity. So 20 to 30% of patients undergoing ERCP, we have encountered duodenal diverticula. So there are several types of diverticulars. The problem is here, there is a giant diverticula, and the thin wall, the wall of the diverticulars are very thin. So you have to be very careful while making pre-cutting incisions for such cases. And you see with a nice pre-cut incision, we have entered into the bile duct. And this is another case. You see a papilla is located at the edge of the, you see, a diverticula. The mucosal fold overlying the papilla bile duct is so very lax and mobile, and so it is a very, very problem for us. But this time we were lucky to make primary cannulation with the guide wire and the sphincterotomy. You have to be very careful by making endoscopic sphincterotomy for such cases because you can easily perforate the diverticular wall in this cases. So you see very difficult case and very difficult papilla located at the edge of the diverticula. We had performed several pre-cut attempts, but fortunately we were able to perform the cannulation at the end. And this is a NODA type 3 diverticula. You see that there is papilla located between two diverticulars, and since it's a fixated structure, it was very easy to perform the cannulation. And lastly, we couldn't find the papilla. What we should do? Of course, first of all, look for the previous gastric surgery. If the patient had a gastrectomy, several types of gastrectomy. So, if not, and the gastroduodenal anatomy is normal, the first place you should look for is, of course, the bulbus of the papilla. This is called as the bulbar papilla. And this is bulbar papilla. And the duodenoscopic view here, and you see a giant ulcer here, you see? And most of the time, ulcer is the etiological factor for ectopic placement of papilla. And the difficulty of ectopic papilla is that you have to work in long position of the duodenoscope in ectopic papillas. So the precutting is so difficult, cannulation is so difficult, but in long position you can even perform a precutting incision, as you see, but you have to be very careful because such kind of papilla do not have enough sphincteric structures, weak sphincteric structure they have, and following a limited sphincterotomy, we have performed a cannulation, and after that, since the procedure was very difficult, in order to prevent micro perforations, so we have placed a self-expandable full cover stent. My last slide. And this is the report that we have previously reported, and the article, and that if you have enough experience, you may have similar results for the ectopic papillas with the normal localization papillas. And finally, cholecystoscopy, and you may sometimes need to examine the intraluminal bile duct, and if you have different kinds of cholecystoscopy system, you can integrate one of them into your devices. And if you do not have, you can use pediatric gastroscope for these purposes. And this is intraluminal view of bile duct. You can examine up to right and left bifurcation with the pediatric gastroscope with the guidance of endoscopic ERCP cannula, and also you can obtain biopsy and also obtain cholangiography of the intrahepatic bile duct with this method. And dear colleagues, thank you very much for your interest and the patience, and of course, I also greet with you with all my respect. Thank you very much.
Thank you, Dr. Yilmaz, Professor Yilmaz. We have just the time for one question, in case that there is there, because we are slightly late for the next session. There is a question there.
Dr. Yilmaz, thank you. Dr. Gültekin from İmraniye, Istanbul. Very demanding and challenging procedures. And we are very grateful to you because sometimes preoperatively, sometimes postoperatively, you not only save the lives of the patients, but also as a so-called second victim, you also save the surgeons. There's another new, recently introduced technique, you know it, magnetic compression, especially in liver transplantation practice, post-operative courses, some challenging biliary problems. Have you ever received similar patients in Rendezvous technique, but especially in magnetic compression?
Magnetic compression.
Any comments on it?
Yes,
Thank you.
yes. Magnetic compression anastomosis is a novel technique, and it includes the incorporation of the ERCP endoscopist and also the invasive radiologist. So there are two magnets placed, one from the invasive radiology to the proximal site of stricture or the injury, and the other from the other side, from the bile duct, from the gastrointestinal system by the ERCP endoscopist. Then these two magnets then come closer by time, and after that they come together and produces another orifice, artificial way in the bile duct. So, and with the placement of a guide wire, then another stent is placed. So, this is suitable for the, I think, strictures most of the time, not acute injuries. I do not have any enough experience, and I do not have any such patient, but I know that, for example, famous gastroenterologist Erkan Parlak have a nice experience on this, and I know and I follow the articles of Erkan Parlak, but it can be performed. If you have experienced invasive radiology specialist in your clinic, it can perform, because the role of ERCP endoscopes in these cases is just to make a ERCP and to place a magnet at the distal end of the bile duct. And after that, the role is, of course, of the invasive radiologist then.
Another question there.
Thank you for your nice presentation. I have a question for you. Do you have any experience about the treatment of the acute cholecystitis with catheter placed through the cystic duct or not?
Actually not, and I'm not sure if it is true or not also. But for severe cholecystitis, we have a different approach for the clinical presentation like Mirizi syndrome with the high bilirubin levels, for example. We have placed a biliary stent before the cholecystectomy in order to prevent the bile duct injuries, because we know that the patient with the Mirizi syndrome, it's a kind of severe cholecystitis, the bile duct injury rate is so high. So we have this is a prophylactic standing. This is our clinic's approach. There is not enough data supporting it, but we have now collecting these data in order to make an article, but not through the cystic duct. So if we consider like this, we have to, I think, perform cholecystostomy in this time, because cystic duct may be anatomically not appropriate for a stent placement.
Thank you very much.
But there are such cases, of course, small, and the large caliber cystic duct, or the gallbladder directly entering into the bile duct. Then, of course, in this time, ERCP, of course, produces drainage of such kind of gallbladder through the cystic duct, of course, spontaneously.
If there are no other questions, we thank Professor Hillman for the presentation. And I think that we can go ahead with the next session. And I am going to substitute Dr. Biffle.